Welcome once again to 10 Minutes with Harry. We are currently looking at the pacemaker electrocardiograph. And today I would like to discuss with you mode switching. We are currently showing ECGs in the pacing series, and this is number 11, mode switching algorithms. Unless we see a clear P wave or a fibrillary wave or flutter waves on the surface ECG, the identification of atrial tachyarrhythmias with a rapid ventricular response, paced response, is always very difficult. Here is such an example where we can see a rapid ventricular pacing, and just to be sure, you can see the spikes present. One of these types of rapid pacing is what I call the Saturday night syndrome. This used to occur quite frequently with me on a Saturday night when I was out visiting, and I would be called into the hospital because the patient was in the ER with a rapid ventricular pacing, such as here, DDD upper rate 120. On reprogramming to VVI, one can see the reason for this is atrial fibrillation with a slow ventricular response, indeed regular and wide QRS, and this is complete heart block. And so the patient, when VVI 30, we can bring out the native rhythm. Here we can see mixed ventricular pacing and conducted tachycardia. So we can actually determine what is going on. Firstly, we can see a ventricular pace beat, and we can also see a native beat at a similar rate, wide QRS. And this is atrial fibrillation, where the pacemaker has been generally not pacing unless, and it's generally at a fast heart rate that you can see the ventricular pacing because of underlying atrial fibrillation. Sometimes we see a pause, and that's very helpful. As we can see here, we look for the pause, and we can see two pauses with the patient pacing, and we can see now that there is a atrial fibrillation. There are no P waves related to either sinus rhythm or an atrial tachyarrhythmia. So this is due to atrial undersensing, which occurs generally with atrial fibrillation. So there will be periods where it doesn't follow very rapidly and we have pauses. How did we treat this tachycardia? What about dual chamber pacing without rate control? Well, we have a number of pacing options available. We can have dual chamber pacing where we keep the upper rate very low, such as 80 beats per minute. And this can be useful in the very elderly patients who are not very mobile. We can go to VVI pacing, or we can use dual chamber pacing, DVI, where there's no atrial sensing at all, but only atrial pacing and of course ventricular pacing or sensing. And then DDI, where there is atrial sensing, but no triggering of the ventricle during these tachycardias. And this is still very useful in patients where we're going to talk about mode switching is not particularly helpful. So automatic mode switching, the objective was to sense inappropriate paroxysmal supraventricular tachyarrhythmias so as to protect the ventricles from persistent rapid pacing. We need to maintain AV conduction during arrhythmia-free periods. So the algorithms allow automatic switching from atrial tracking mode to non-atrial tracking mode upon sensing of a paroxysmal supraventricular tachyarrhythmia. But even though we have no atrial tracking, we still maintain atrial monitoring during the non-atrial tracking mode. And this is generally two modes, VVI, or because there is sensing in the atrium, VDI, or there is DDI, where there is no tracking, but there is, as I stated earlier, atrial sensing. There is automatic restoration of the atrial tracking mode upon cessation of the supraventricular tachyarrhythmia. With mode switching, the appearances of VVI pacing. And you can see here that there is underlying atrial flutter or fibrillation, and that the regular pacing with a wide QRS, and we look at leads generally 3, 4, or 5, B3, 4, or 5, where it is easiest to see the stimulus artifact. What about DDIR mode switching appearance? Well, when it's in a DDIR mode, we have atrial pacing can occur when there is atrial undersensing. Look at this example. It looks like ventricular pacing with underlying atrial fibrillation. But occasionally we see atrial stimulus artifacts as well. This is because there is atrial undersensing, and because it's programmed to a dual chamber mode, it continues to pace the atrium as well during these periods of undersensing. Let's have a look at an example of a Holter monitor with inappropriate mode switching. This is a bizarre appearance to the heart rate histogram. We can see that there is a rate of 70 beats per minute for almost half of the study. And when we look at the electrocardiographs, we can see where the red arrow occurs that there is a transition from dual chamber rapid pacing to a pacing which is just VVI. And during the tracing, during the period where it's 70 beats per minute, it is simple ventricular pacing, in this case, just VVI. When it's at 110 beats, which is at its upper rate limit, one can see, therefore, no mode switching with a rapid ventricular pacing, but also at times we can see atrial fibrillation with a rapid ventricular response. In this situation where there is inappropriate mode switching, we can use DDIR pacing. So what have I learned? With dual chamber pacing, sensing of rapid atrial tachyarrhythmias will result in inappropriate rapid ventricular pacing. You require clues to identify ventricular pacing. You require clues such as pauses to identify the atrial rhythm. Today, programmable automatic mode switching algorithms can identify these rhythms and revert to DDIR or VDIR pacing. They are very reliable. However, on occasion, we find that they do fail, particularly with resulting in rapid ventricular responses to pacing, and therefore dual chamber DDIR pacing may be required. Thank you.